I want you to picture a battlefield. But I don't want you to imagine soldiers or trenches or tanks.
Right.
I want you to imagine a biological battlefield. And right in the center of it, dropping into this hot zone, is a human body that is tiny, still developing and, well, exploring the world for the very first time.
It is a terrifying image when you frame it exactly like that, but biologically speaking, it's completely accurate. The sheer volume of things trying to attack a child's body at any given moment is staggering.
It really is. And that's why today we are doing a deep dive into a massive stack of medical educational notes focused on pediatric nursing.
A very heavy stack.
Yeah, exactly.
Yeah.
We aren't just skimming the surface here. We're looking closely at the dermatological disorders and communicable diseases section, and of course the tactical manual we use to fight them off, immunizations.
We're covering everything from microscopic viruses that cause rashes with bizarre, highly descriptive names to parasitic bugs that invade elementary schools, all the way up to life-threatening skin emergencies.
And the mission for you, the listener, isn't just to memorize a list of diseases and gross you out, though some of this is pretty gross.
Very gross.
But the goal is to decode the jargon. We want to understand the visual clues, the specific signs doctors and nurses are trained to spot instantly, and the massive scientific effort behind how we stop them. Because reading through this, I realized that half the battle is just knowing what you're actually looking at.
Exactly. In pediatrics, observation is your absolute superpower. A 6-month-old can't look at you and tell you, hey, my throat hurts, or I feel dizzy.
Right. They just cry.
They just cry. You have to look at the skin, the tongue, the behavior.
Yeah.
You have to be a detective.
So let's start where the medical logic starts.
Mm.
Prevention. The first line of defense. The shield wall. We are talking about immunizations.
The most effective tool in the kit.
Now, looking at the administration protocols in these notes, I was struck by how much strategy goes into just the physical act of giving the shot. I think most adults picture, walking into a pharmacy, rolling up your sleeve, getting a jab in the arm, and leaving.
Sure.
But for an infant, you can't do that.
No, absolutely not. If you look at the anatomy of an infant, the deltoid muscle in the arm is tiny. It's undeveloped. If you inject there, you risk hitting a nerve or striking the bone.
Ouch.
Yeah, it's bad. So the clinical guidelines are very specific. For anyone under 12 months, or really until they're walking well enough to build up some muscle mass, you target the upper vastus lateralis.
Which is the thigh muscle.
The outer thigh, yes. It's the largest, safest muscle mass a baby has. It can absorb the medication effectively without causing any structural damage.
It's not just where you stick them, it's how. The protocol for parents caught my eye because it treats the parent like a member of a tactical team. It's not a passive role at all.
No, they have to be actively involved. Holding the child in a specific way using distraction techniques rewards needle anxiety starts early. And if a parent is anxious, the kid feels it immediately.
But there's a crucial rule here regarding the pre-flight check, if you will. The notes call it a contraindication check.
Ah, yes. The can we actually give the shot today a check? I see parents struggle with this constantly. And the biggest misconception, the one that causes the most unnecessary delays, is the common cold.
Because parents think, oh, he has the sniffles, a little low-grade temp, maybe he's cranky. We should just skip the vaccine to be safe.
Right. It feels intuitive. You don't want to overload the system.
But the science says otherwise.
Completely otherwise. The notes are explicit here. Minor illnesses are not a valid reason to delay vaccination. The human immune system is incredibly robust. It can handle fighting a mild cold and processing a vaccine simultaneously without breaking a sweat.
So sniffles are a green light.
Sniffles are green. The only real stop sign is a significant fever. If the child is actively febrile, you delay. But otherwise, you stick to the schedule.
Okay, speaking of the schedule, let's look at the roster of vaccines themselves. There are some surprising details in the manufacturing of these things that act as hidden traps for the unaware. Take hepatitis B, for example.
Hep B is usually the first one. It's a 3-dose series that starts right at birth.
But there's a warning here about yeast.
Yeah, that catches people off guard all the time. The hepatitis B vaccine is recombinant, meaning it's actually grown inside yeast cells. Baker's yeast, essentially.
Wow.
So on the intake form, when it asks about allergies, if a parent skips over yeast because they think, well, my kid doesn't eat sandwiches yet, they could be missing a critical contraindication.
That is fascinating. It's a supply chain detail that becomes a medical safety issue. Then you have rotavirus. This one stood out to me because it breaks the whole shot pattern entirely.
Right, it's oral. Drops right in the mouth. Rotavirus causes severe watery diarrhea. In the developing world, and even here before the vaccine, it was a leading cause of severe dehydration and death in infants.
But there is a specific history warning here. Intussusception. That is a mouthful of a word, and it sounds terrifying.
It is a very serious condition. Imagine a telescope collapsing into itself.
Oh, wow.
Yeah. Intussusception is where one part of the bowel telescopes into an adjacent part. It causes a blockage, swelling, and it can actually cut off blood flow. If a baby has a history of that occurring, the rotavirus vaccine is a hard no-go.
Because the vaccine works in the gut, so it could irritate that mechanism.
Exactly. There is a tiny theoretical risk it could trigger it again. So you balance the risk of the virus against the history of the gut.
Now, let's talk about the flu. Influenza. The annual ritual.
A requirement for anyone over 6 months old.
But there's a rule here for rookies that I totally didn't know. If a child is under 8 years old and getting the flu shot for the very first time, one shot isn't enough.
It isn't. Think of it like learning a new language. If you're an adult and you've had flu shots before, your immune system sort of remembers the drill. But for a young child, their immune system is naive to the influenza virus. It doesn't know what it's looking at.
So the first one is just practice.
The first shot is just an introduction, a simple hello. The second shot, given 4 weeks later, is the, hey, remember this. That is when the immunity actually locks in.
And for the parents who want to avoid the needle and ask for the nasal spray, the notes put a massive red warning label on that for kids with asthma.
This brings up a vital distinction in immunology. The regular shot is an inactivated virus. It's dead. It literally cannot give you the flu. The nasal spray, however, is a live attenuated vaccine. It uses a weakened but living virus.
And because it's sprayed right into the respiratory tract.
Exactly. In a child with asthma, that irritation from the live virus can trigger wheezing or a full-blown asthma attack. So asthmatics get the needle, never the spray.
That distinction between live and inactivated seems to control a lot of the rules in this stack. We see it again with MMR measles, mumps, rubella, and varicella, which is chickenpox. Those are live vaccines too.
They are, and because they're live, the rules are much stricter. We generally don't give them to kids who are severely immunocompromised, like those on chemotherapy, for instance. Their bodies just can't handle the fight, even against a weakened opponent.
There was another contraindication for live vaccines. It felt like a logic puzzle. Recent antiviral medication.
This is pure clinical logic. Think about it. You are injecting a live virus, the vaccine, to teach the body how to fight it. If the child has taken an antiviral drug recently, that drug is still circulating in their blood. What do antivirals do?
They kill viruses.
They kill viruses.
So the medication kills the vaccine before the immune system can even learn from it.
Precisely.
Yeah.
You're sending a training dummy into a room, but you've already cleared the room with a flamethrower. The training fails because the target is destroyed way too quickly.
That makes perfect sense. And we should also mention that with all these shots, parents have to be given a VIS, a vaccine information statement, and any adverse effects, like high fevers or extreme irritability, have to be reported to the CDC.
Yes, the reporting and tracking system is incredibly rigorous to ensure safety.
Okay, so we've armed the immune system, we've built a shield wall, but no defense is perfect. Sometimes the enemy gets in. This brings us to segment 2, the rogues gallery of viral communicable diseases.
And this is where the visual detective work really kicks into high gear.
Reading these descriptions, it feels like these viruses have brands. They leave a specific signature. Let's start with fifth disease.
Caused by parvovirus B19.
The notes describe the slap cheek appearance.
It's unmistakable. It literally looks like someone slapped the child hard across the face. You get these bright red, angry cheeks. Then, a day or so later, a rash appears on the body that looks lacy. Yeah, it's not solid red. It has a pattern to it, almost like a doily. It's a vascular response. For most kids, this is mild. But if a child has sickle cell disease, this innocent-looking virus is highly dangerous. Parvovirus attacks the bone marrow's ability to make red blood cells. In a sickle cell patient, that can trigger a severe crisis.
So the stakes change wildly depending on who the host is. Then we have hand, foot, and mouth disease. The name is literally the map of the symptoms.
It is. You get painful vesicles, blisters in the mouth, on the palms of the hands, and on the soles of the feet, sometimes the buttocks too.
The notes emphasize that the danger here isn't usually the virus itself killing you, it's a secondary effect.
It's refusal to eat or drink. Those mouth sores are incredibly painful. Imagine trying to drink orange juice with a mouthful of raw ulcers. Kids just stop drinking entirely. So the clinical focus isn't really on curing the virus, it's entirely on hydration. We just have to keep fluids going until the storm passes.
Now, we have to talk about the heavy hitters. Measles. Rubiola. I feel like because of vaccines, we've kind of forgotten how scary this one actually is.
We have. Measles is a systemic assault on the body. It is not just spots. It can cause severe pneumonia, encephalitis, which is brain damage from swelling, and death.
There's a specific tell for measles before the rash even appears on the body. Koplik spots.
Doctors hunt for these. They are tiny red spots inside the cheek near the molars with a bluish-white center. The textbook description is that they look like grains of salt on a red background.
If you see the salt, you know the storm is coming.
Exactly. And the rash itself follows a gravity pattern. It starts up at the hairline and travels downward to the feet over a few days.
Isolation is huge here. The notes say airborne precautions are non-negotiable.
Measles is one of the most contagious viruses known to man. It hangs in the air for up to 2 hours after a sick person leaves the room. You need heavy-duty isolation. 5 days after the rash appears, at minimum.
Wow. Contract that with roseola. This one feels like a prankster or trickster virus.
It really is a trickster. With roseola, the symptoms seem entirely backwards. You start with a terrifyingly high fever, 103, 104, maybe 105 for 3 to 7 days. The child seems fine otherwise, just burning hot. But that fever spike happens so fast it can cause febrile seizures, which is an absolute nightmare for parents to witness.
And then what happens?
Then, abruptly, the fever breaks. The parents think, oh, thank goodness it's over, and boom! That is the exact moment the pink rash appears on the trunk. The rash is actually the sign that the child is recovering.
So, fever first, rash later. Unlike measles, where they overlap.
Correct. The timing of the rash tells you which virus you're dealing with.
Let's hit one more in the viral squad. Chickenpox. Varicella. We know it itches. But how do you tell it apart from, say, a bad bug bite or a heat rash?
The key phrase in the medical notes is lesions in different stages.
Unpack that for me.
With most rashes, all the bumps look the same. With chickenpox, if you look at the child's back, you see a timeline. You see some brand new red bumps, you see some fluid-filled blisters that just formed, and you see some that have already popped and crusted over, all existing simultaneously.
And that cresting is the finish line.
Yes. You are contagious until every single vesicle has crusted over. No more open sores. That's the hard rule for going back to school. Airborne and contact transmission is no joke.
And before we leave viruses, we should mention rubella. The risk there isn't actually just to the child who gets it.
Right. The real danger with rubella is to pregnant women. Congenital rubella syndrome can cause devastating heart defects, deafness, and even fetal death. It's why herd immunity is so critical.
All right, so we've done shots, we've done viruses. Now I want to move to the section of the notes I've affectionately dubbed itchy and crusty. We were leaving the viral world and entering bacteria, fungus, and parasites.
I can certainly see why you chose that name. The descriptions here get very textural.
Let's start with impetigo. The source gives a description I will never get out of my head. Honey-colored crusts.
It is the iconic description in pediatric dermatology. Impetigo is a bacterial infection, usually staph or strep. It typically happens right around the nose and mouth. The sores break open and the fluid dries into that distinct golden honey color.
It spreads outward?
Yes, peripherally. The edges of the rash keep expanding, and it is highly contagious. Kids touch their nose, touch a toy, another kid touches the toy, you get the picture. You absolutely need antibiotics for this one.
Then there's scarlet fever. This is linked to strep throat.
Right. It's caused by group A strep bacteria.
2 visual clues here. First, the strawberry tongue.
The tongue gets swollen, red, and covered in bumps. It looks exactly like a strawberry.
And the rash. The notes say it has a very specific feel to it.
It feels like sandpaper. It's a fine red rash, usually starting on the groin, neck, and in the skin folds. If you run your hand over it, it's rough to the touch.
We also have pertussis here. Whooping cough.
A brutal bacterial infection. The name comes from the sound, that desperate whoop they make gasping for air after a coughing fit.
And the notes mention it gets so bad it leads to vomiting and cyanosis.
Yes, turning blue from lack of oxygen. It is exhausting for the child and terrifying to watch.
Let's switch kingdoms to fungal infections. Kiana.
Right. And please, for the love of clarity, ringworm is not a worm.
Say it louder for the people in the back.
It is a fungus. It is the exact same type of fungus that causes athlete's foot. It just happens to grow in a circular pattern, which looks like a worm buried under the skin to the untrained eye.
The notes basically break this down by real estate. It's all the same invader, just different locations.
Exactly. It's all Tina. If it's on the scalp, it's Tinea capitis, and this can cause patches of hair loss or alopecia. If it's on the body, Tinea corporis, the classic ring. If it's in the groin, Tinea cruris, and Tinea pedis is feet. The treatment is antifungals. Do not buy dewormer.
Moving down the size chart to parasites. Lice.
Huh.
Pediculosis. The absolute bane of every elementary school parent and the nightmare of the PTA.
Truly. Now, the adult lice are hard to see because they move fast. So diagnostically, we look for nits.
The eggs.
Right. They look like tiny white specks on the hair shaft. Now, people often confuse this with dandruff, but here's the field test. Shake the hair or try to flick the speck. Dandruff falls like snow. Nits are glued on with a cement-like substance. They do not move.
The treatment mentioned is permethrin shampoo. But there was a weird contraindication here that I never ever would have guessed. Ragweed allergy.
Yeah, this is biochemistry at work. Permethrin is a chemical derived from chrysanthemums. Chrysanthemums are in the same botanical family as ragweed, so if a child has a severe ragweed allergy, putting this shampoo on their scalp could trigger an allergic reaction.
That is such a random connection. Ragweed and lice shampoo.
It's why you always check the history, even for over-the-counter stuff.
And the home care, the notes, suggest a scorched earth policy. Wash everything in hot water, but for the things you can't wash, like a giant teddy bear.
Bag 'em and tag 'em. You seal them in a plastic trash bag for 14 days.
Why 14 days? Why not just leave it overnight?
Starvation. Lice need a blood meal to survive. They can't live long off the host. But the nits, the eggs, can hatch after a week or so. By keeping the bag sealed for 2 weeks, you ensure any eggs hatch, find no food, and die. It breaks the life cycle completely.
Brutal. I love it. Okay, final segment. We've covered infection. Now I want to look at trauma and skin emergencies. This is where the skin isn't just itchy, it's under attack or compromising the body's integrity.
This is the high-stakes section.
We should quickly mention acne here, too. The source highlights that it's not just cosmetic. There are significant self-image and self-esteem problems tied to it. The whiteheads and blackheads, comedones. It really affects kids mentally.
It does. And treating it is as much about psychological well-being as it is about dermatology.
Let's talk about cellulitis. This isn't just surface skin. This goes deep.
It's an infection of the dermis and subcutaneous tissue. Usually staph or MRSA enters through a cut or a bug bite. The area gets red, hot, swollen, and firm.
There is a specific warning sign here called red streaking.
This is critical. If you see a red line shooting out from the infection site traveling up the arm or leg, that's the bacteria moving into the lymphatic system. It is using the lymph nodes as a highway to go systemic. That is a massive medical emergency.
The note suggests a very low-tech tool for monitoring this, a pen.
It is the best tool you have. You draw a circle around the redness on the skin. You write the time right next to it. If 2 hours later the redness has crossed that ink line, you know the infection is aggressive and the current treatment isn't holding it back. It gives you objective data to show the doctor rather than just saying, I think it looks worse.
That's a great tip. Mark the redness. Let's move to anaphylaxis, specifically insect stings.
This is a systemic allergic reaction. The throat closes, blood pressure drops. It is life or death.
We all know about the EpiPen, but the instructions here were more detailed than just stab and go.
People panic. They stab the thigh and immediately pull it right out. That is a mistake.
The notes say 90-degree angle into the thigh and hold for lick.
10 to 15 seconds.
That feels like an absolute lifetime when a kid is choking.
It does, but the medication is viscous. It's thick. The spring mechanism needs time to push the full dose deep into the muscle tissue. If you pull out too fast, you waste the life-saving drug. You have to count it out.
Finally, burns. The notes classify them 1st through 4th degree, with 4th going all the way down to muscle and bone. But what determines a major burn isn't just depth, it's location.
Correct. You could have a relatively small burn, but if it's on the face, hands, feet, or genitalia, it is automatically classified as a major burn.
Why is that?
Functionality. Scar tissue on your back is cosmetic. Scar tissue on your hand can fuse your fingers together. Scar tissue on an eyelid can prevent it from closing ever again. These areas need specialized burn center care to preserve function, not just heal the skin.
There was one detail about burns that terrified me. The silent killer in smoke inhalation.
Airway obstruction. This is the one that catches people off guard.
The notes mention that a child can inhale hot smoke, look perfectly fine initially, and then
24 to 48 hours later, the airway swells completely shut.
2 days later.
Yes. The thermal injury triggers swelling in the tissues of the throat, but it's not instant. It creeps up. That's why we monitor for stridor, that high-pitched gasping sound. If a child has been in a fire or inhaled smoke, you don't send them home just because they look okay. You watch the airway like a hawk for that delayed reaction.
So when we look at this entire stack, from a microscopic virus causing a slap cheek look, to a physical burn injury, to the complex manufacturing of a yeast-based vaccine,
Yeah.
it just feels overwhelming.
It is a lot of information, but if you connect the dots, there is a single theme running through all of this.
Which is
Observation.
observation.
Yes. Medicine isn't just labs and scans. It's noticing the strawberry tongue. It's marking the red streak with a pen. It's realizing the fever broke before the rash appeared. The intervention relies entirely on catching those visual clues.
It's about knowing what to look for in the chaos.
And respecting the body's attempt to communicate what's wrong.
You know, there's one final provocative thought that stuck with me for you to mull over. We talked about all these massive interventions, vaccines, antibiotics, EpiPens, but for so many of these viral issues, mono, hand, foot, and mouth, roseola, the notes just say supportive care, fluids, rest.
That's the reality. For a huge portion of these threats, there is no magic pill. We can treat the symptoms, but we can't kill the virus.
It really highlights that despite all our technology and all our medical battlefields, the ultimate weapon is still the child's own immune system. Sometimes the only thing we can do is wait for the body to fight its own war. What does that say about the resilience of the human immune system?
We just buy it time to do its job. It's an incredibly resilient system, if we give it the chance.
A fascinating deep dive into the things that attack and how we fight back. Thanks for listening.
Stay healthy out there.